Good evening, one and all. I'm Dr. Sampada Kulkarni. I'm a pediatric physiotherapist. So I'm working at NeuroGenBSI. Today's topic of discussion is overcoming challenges and nurturing potential of children with spastic dystonic cerebral palsy. So before moving on to the challenges that they face, let's understand what cerebral palsy means. Cerebral palsy describes a group of permanent disorders of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in developing fetal or infant brain, which means that it basically is a non-progressive disorder which affects the developing brain, which can affect, the causes will have on the prenatal, natal and postnatal duration of life. What is the prevalence? Which means how many children are affected in India. Approx 1.5 to 3 live births in CP of CP children are affected in India. So cerebral palsy not only affects the motor disorders, but it also accompanied by the disturbances what it causes on the sensory system, on the perception, on the communication, behavior. It can also cause epilepsy or also cause a lot of musculoskeletal problems. What are the causes of CP? As I told you, there are three main causes: prenatal, natal and postnatal. Prenatal meaning from the time of conception till the delivery. So gestational hypertension is the first cause. This means that during the time of pregnancy, the mother can experience increase in the blood pressure, which could further lead to complications. Secondly, gestational diabetes. During the time of pregnancy, gestation means that is the time of pregnancy. During the time of pregnancy, the mother experiences increase in the blood sugar level, which could further lead to complication, which also might lead to cerebral palsy. Thyroid can be hypothyroidism or hyperthyroidism. Stress, fall or injury, infection like toxoplasmosis, rubella, cytomegalovirus, and hepatitis virus, or addictions like drug substance or any smoking or alcohol. What are the natal causes? Natal meaning during the time of delivery, what can happen? What can go wrong during the time of delivery? That is breech presentation. Breech means the child's legs and buttocks are downwards while it's born. That could lead to a lot of complication like cord strangulation, which could further impact the development of the child while it grows. Birth weight. The normal birth weight ranges from between 2.5 to 3.5 kgs. So the lower birth weight is considered when the birth weight is below the 2.5. Birth cry. Usually the child should immediately cry after birth. But if there is some delay in the cry, there could be hypoxia, that is lack of oxygen supply to the brain, which could further lead to cerebral palsy. Premature birth or a prolonged labor. Assisted labor, that could be with forceps delivery or vacuum delivery. Meconium aspiration. Meconium aspiration is when a child inhales its own fecus during the process of delivery, which could further, that fecus could go into its own lungs, and that child might have respiratory distress, which could further lead to CP. What are the postnatal causes? That means after delivery, what all could go wrong? Apgar score. So this is a scale which is taken by pediatricians during the 1st and the 5th minute of life, which states Apgar meaning appearance of the child, pulse, grimace, activity and respiration. So all of these components are very important for us to understand if the child is normal or no. The normal scoring is between 7 to 10. Respiratory distress, severe or a pathological jaundice. Children go through, neonates have neonatal jaundice or a physiological jaundice, which is considered to be normal, but pathological jaundice, which is like more than 7 days, if the child still continues to have jaundice, then that is abnormal. Seizures, viral encephalitis, bacterial meningitis, and hypoglycemia. So these are the probable or the possible causes which could cause cerebral palsy. Now, how to identify the early markers? So it's very important for parents and caregivers to understand the importance of observation, because they are the ones who will observe their child more frequently than the pediatricians or a physiotherapist. So let's understand what a normal child is first. In the first picture, if you can see, Normally, the child is when the child is suspended on the tummy, the child tends to hold his neck, and you can see some of the muscles are active or he is active. But in the abnormal side, if you see the child's, the child is floppy and then there is no activity happening and the child looks very dull. While in the second image, if you see child is crying with a flex or a bent posture that he has attained, whereas in the abnormal pattern, if you see the child is arching its own back, which is not normal, the child should not be arching its back, which can be considered that there's a brain pathology. In the normal section, if you see neck control, the child is able to hold its neck, whereas in abnormal side, usually around 3 months, the child has to learn to hold its neck. But then if the child is not doing that, is considered to be abnormal. The crying should be normal and it shouldn't be very excessive or high pitched, or the child shouldn't be very irritable. The child should have good sucking reflex, but if there is a weak sucking reflex or the child refuses to do latching or the child does not want or refuses to feed, then that's a problem. So as you all saw that these were the early markers. Now let's move on to the signs and symptoms. So signs and symptoms are divided in early infancy and late infancy. So in early infancy, if you can see within 3 to 6 months, how can we diagnose or how can we see if a child has some physical or any issue? So the child will be slow to reach its developmental milestones. So there are appropriate ages given for like months given for the child to attain its own development. Example, 3 months head control, 4 months rolling, 6 months should be sitting with support, 8 months crawling and all of those. But if you see that there is some delay in attaining all of these developmental milestones, the parent has to make a record of it and keep so that they can observe better about it. And if a child is crying or it's high pitched cry, as I told you, is if the child is very irritable, then if the head falls back excessively or the head is falling in front, which can state that the child is not having a better neck control or a trunk control. So if the child will be stiff, that means if you hold a neonate, you will not find it normally stiff. But if you feel that the child is stiff, that means there is some pathology it has. The baby will be floppy. The neonate should not usually be excessively stiff or excessively floppy. It should be able to hold on to himself. When we are holding, you'll understand that the child, when you hold a child, you understand if the child is very loose or it's letting itself on the body. The next point is seems to overextend back and neck when cradled in somebody's arms. That means when you hold a neonate, you will see that the child is in a bent or a flexed posture. It will just try to cushion itself. But then in abnormal signs, the child, as I told you, might over or hyperextend the back or arch its back, which is not considered to be normal. While if you lift a child, you can see the child is having a tendency of crossing or having a scissor pattern, which also is one of the signs and symptoms of pathology in the brain. Next, moving on to 6 months. In 6 months, if you see the child is not rolling over in either direction, or if the child cannot bring the hands together, or the child has difficulty in bringing its hand to the mouth, if the child is reaching onto an object but only with a particular hand or the hand is fisted, that also can be a sign of having some pathology. Moving on to 10 months or older, the child crawls in a lopsided manner, meaning it's uneven, it is not even. And during 8 months of life, usually the child should be learning to crawl. But then if the child is not doing that, if the child is trying to scoot or trying to hop on the knees, that also could be one of the possible signs of some delay happening in the milestones. But we need to rule out those delays. We cannot just say that the child is not doing this, so there is some problem with him. We'll have to observe him for a longer period of time, consult a better doctor for it, consult the physiotherapist for it, and then look around and then diagnose. In late infancy, usually the child, when it learns to walk, it walks in a waddling or a wide base of support. It tries to hold on to himself in high guard. But then if the child is not doing that, the child might be walking on tippy toes, or if the child is unable to speak words, if the child is only using one side of the body and is not using the other side, and the child has abnormal behaviors like irritability or lack of concentration, these are also the signs and symptoms, but we have to rule them out with time and with better observation. Now, moving on to the classification of CP. So, cerebral palsy, as I told you, is a vast topic, and we'll have to understand what all comes in which all parts. So, CP is divided into three types, that is a topographical classification, physiological, and the GMFCS classification. Topographical is based on the parts of body which is affected. Physiological is based on the muscle tone of the body or the control of the body which is affected, and GMFCS is based on the functional level. It's a scale which tells you about the functional level of the child. So what is topographical classification? It tells you about the part or a limb that is affected. If you see the first image, monoplegia, which means one limb of a child. Any one limb of a child will be affected. Second is hemiplegia. That means one side of the body is affected. The third is diplegia. That means the lower limb is more affected than the upper limb. Third is triplegia. Any three limbs will be affected. While the fourth one, the last one is quadriplegia, where all four limbs are affected. We will move on to the details of this in my further slides. Moving on to the physiological classification, which tells us about spastic, dyskinetic, ataxic, and mixed. So what do you mean by spastic? Spastic over here means it is characterized by stiff posture or muscle tightness or stiff joints, which are usually underdeveloped. The muscles are not they're not loose, they are very firm and stiff. You will feel that there's stiffness in the muscles. Dyskinetic means the patient who performs activity which is involuntary, it's not in their control, and the movements might range from increase or decrease and can change frequently over time. That is dyskinetic. Ataxia meaning loss of smoothness of the movement. There is motor coordination loss. Mixed is a combination of all the above mentioned types. Now, the next one is GMFCS level. GMFCS level has 5 levels. That we can start from the 5th one. Level 5 tells us about the child who is completely dependent on the wheelchair, and he will be dependent on for the activities of daily living also. Level 4 will tell us that the child is self-mobile but only can operate the motorized wheelchair and will require assistance for its transfers. Level 3 will tell you that the child can walk around with assistive and adaptive devices but under supervision and in the home environment. Level 2 will tell us about that the child will try to walk with limitations under supervision, will have some difficulty in walking over uneven surfaces or terrains. Level 1 is the GMSS level 1 will tell us about the child that is he's good in his gross motor functions but will sometimes require support or supervision for his balance, coordination and speed. So all these were the types of cerebral palsy. Now let's understand the types of CP in detail. For understanding that in detail, let's first know what area of brain affects each type of CP. For spasticity, the cerebral cortex, if you see this area is affected. That's the major area of the brain that is affected. For dyskinesis, dyskinetic CP, basal ganglia, this is a smaller part of the brain which controls the movement and coordination that is affected. That is affected. Cerebellum, which is a small brain that we call cerebellum, where ataxia happens. If there is damage to the cerebellum, there is ataxia, loss of coordination, loss of balance, which is caused by damage to the cerebellum. And mixed is a combination of 2 or more types associated with the damage, wherein the multiple areas of brain are affected. Now, what is spastic cerebral palsy? Our topic for today is spastic dystonic CP. So I'll be explaining to you what spasticity and dystonia is in detail. So spastic cerebral palsy is the damage to the motor cortex of the brain. It is the most common form of CP which affects almost 70 to 80% of cases. There are a few types in the spastic CP. That is, first one is the hemiplegic CP. So if you see in this image, in hemiplegic CP, his one side of the body is completely affected and the opposite side of the body is normal. That means the affected side will be little bent, the shoulder and elbow will be little bent, the wrist will be fisted, the wrist will be little flexed inwards, and the affected side limb, he'll be either on tippy toes or either will be severely hyperextended. Or he might walk on tippy toes or he might even drag the leg sometimes. So hand function of the affected side will be affected. The child may walk on toes. Understanding may or may not be affected, and the affected parts, eye could also be affected. It could be he might be squint, or he might have strabismus. If you see this image, in this the child is on tippy toe where the knee and hip is bent. So the opposite side is completely normal, whereas in the other image, the child is extending his hip and knee severely, and he might drag his affected side. What is diplegic CP? So diplegic meaning lower limb is more affected than the upper limb. The leg will be very stiff, but there will be some amount of spasticity in the upper limb as well, but the lower limbs are severely affected in the upper limb. Trunk muscles will be affected. There will be tendency where the child stands with bent knees. If you see the images, this child has hip and knee is internal rotated, and the knees crossing over each other while the leg ankles are also in inversion, and the child is on tippy toes. Speech will be affected. Understanding may or may not be affected. The child will have difficulty in balancing while standing or walking, which depends on the severity of the condition. Now, in this image, if you see, this is a classical feature of spastic diplegia having scissor pattern. The second most common type is the crouch pattern, wherein the hip and knee is bent, ankle is pronated and collapsed inwards. And in this, the hip and knee is crossed, and there is tightness or spasticity of this muscle, that is adductor muscle of the hip. Quadriplegia, this is the severe form of CP wherein all four limbs are affected. The speech may or may not be affected. Speech will be affected, sorry, and understanding will be affected. Neck control may or may not be affected in this. In this image, if you can see, the child has his shoulder and elbow and the wrist are in flexion, that means it's bent. The hip has contracture, that is the outward direction contracture, that is the abduction contracture, what we call. And this also, swallowing and chewing will be affected in this, because the muscles useful for mastication or chewing and swallowing also will be spastic in this. Now let's move on to dyskinetic CP. This is a type of movement disorder where the basal ganglia is affected. Dyskinetic CP is the like it's sustained, like it's involuntary movements or muscle contraction which interferes with the activities of daily living. It's the second most prevalent form of CP. There are three types of dyskinetic CP, that is dystonia, chorea, and athetosis. Let's come on to dystonia. Dystonia is a movement disorder which is characterized by sustained intermittent muscle contraction, which causes abnormal movements and postures of both. So basically, dystonia is a sustained contraction which, whenever you make a child sit or you make a child sleep, do any functional activity, there's a tendency that the child goes into opisthotonus or arching. I shall show you the videos ahead. So dystonic CP often interferes with the child's sleep due to its uncomfortable pain caused by its contractions. It could also be difficult for children with dystonia to sit and lie down because they go in that posture very often. So what are the features? Let me show you the video first. If you see, we are in this video, we are making the child do a functional activity, that is sitting in a better alignment. But then if you see, he is arching himself behind, but this movement is not in his control and it was sustained. Now let's come to the features. Movement that switches between like slow and fast, it's painful and it's not in the control. If the child is anxious or if tired, they might go into dystonia more often. And there is uncontrolled blinking or drooling. What happens? Even the muscles chewing and swallowing is affected because there is dystonia or atrophy in that muscle also. What is chorea? Chorea involves larger, irregular, and rapid contractions, which include like the larger joints, like the proximal extremities. Chorea is a larger, like it involves the larger joint, larger movements, and it can affect the proximal extremity, that is mainly the bigger muscles, that is the shoulder and the hip muscles. It does not appear to be linked with the voluntary movement, But then even if you try to stop it, it will not stop. Or if you try to relax, it might not relax. So it is distinguished with dystonia by its unpredictable and random nature. If you see this video, this child is showing involuntary movements, tremors, unsteadiness. If you see his face, I shall play it again. If you see his face, there is grimacing or drooling. And there's unsteadiness that we can see. We don't know when the movement and which part of movement will come now. Yeah. What is athetoid? Athetosis is a slow, continuous involuntary movement. So chorea was large movement and athetoid is slow movement, which affects the maintenance of a stable posture. So basically, athetosis and chorea, it can be seen in combination of dystonia, like it can be seen together. In this video, if you see, you can see there is shoulder movement, there is arching of back, there is movement in the wrist as well. So there's wrist movements are athetosis, shoulder movements are chorea, and the arching of back is dystonia. So in this video, there is everything together. What is ataxic CP? Ataxia means there is lack of coordination or there is no order. So there is damage to the cerebellum of the brain, and it is characterized by problems with balance and coordination. In this video, if you see a child, ataxic child, she is a classical case of ataxic CP. She is walking with her feet apart. There is trouble for her to get her hands in the midline or together. There's unsteadiness in the gait, like if she is not able to stop her own gait. And there'll be overshooting of movements, there'll be trouble in grasping movements. What is mixed CP? Mixed CP is combination of both, that is spastic and dyskinetic. Mixed CP occurs when a child exhibits symptoms of more than one type of CP. Child will have stiff muscles and involuntary movements both. Now, as we all know, that there are a lot of challenges that children with CP face. What are the challenges and how do they face it? Let's understand that. These are the associated problems that children face in cerebral palsy. That is pain. They might have pain. They have intellectual disability. They are non-ambulatory. They have hip displacement or dislocation. They are non-verbal. There is epilepsy. There's behavior disorder. There's bladder incontinence. There's sleep disorder. There's vision impairment. They are having difficulty in eating and chewing or swallowing. And there's hearing impairment. Now, this topic is very important. I have just selected a few topics for me to elaborate, because hip joint and CP is a very important and essential topic for us to understand, because it's not neglected, but then it's very important for the parents and caregivers to understand the importance of positioning and hip in a child with CP. So let's see children who are at risk of hip dislocation. In the first image, severe hip adduction. This is the scissor pattern wherein the child's both the legs are crossed, excessively crossed. Windswept deformity, where one side of the knee is facing inwards and the other knee is facing outwards. And excessive W sitting, where the child sits with both the legs behind, forming a W shape while it sits, where this also is a very bad posture for not only CP but all the children who regularly sit in this. So parents, please tell them not to sit in this position. The early recognition of at-risk patient at early ages will help in giving early appropriate interventions and avoid orthopedic procedures. So hip surveillance can identify patients at risk of silent progressive hip dislocation. Regular radiographic spine and hip examination is very important and integral part, because physical examination alone cannot be always reliable. So a baseline, like we can at least for a baseline radiographic pelvis should be obtained at least at 12 to 8 months, and follow-up of the same should be done every 6 months interval. And it's very important for children who are non-ambulatory, who cannot walk. And mostly children with CP are not born with problems with the hip, but then because of increase in tone or increase in spasticity or contracture, they go through that phase and have the tendency to get it dislocated. And hip dislocation will really lead to pain and functional impairment, and they might have affected, they might not be able to sit, stand or walk. They might not be able to sit, stand and walk, and they might have impaired quality of life. How can we identify if a child has any pathology or problem with the hip? The child will have difficulty in standing, walking, or performing transfers only because of that part, only because of the hip. There will be excessive hip pain, or the child might cry, indicating that there's pain towards the hip region. There will be restriction in the range. That means if you try to move that joint, if you try to move the hip joint or the any in and around that joint, then there will be pain, and the pain will be severe. Asymmetrical growth of legs, meaning there will be limb length discrepancy. One leg will be shorter than the other. Compromised posture. So if only hip, whenever there's some pathology with the hip, it's not just the hip that's involved, even the spine gets involved because it is connected. So we have to see if there is any compensation of posture, like if there's any increased or abnormal curvature of the spine, or if there is any kyphosis of or bending of the spine related because of the hip joint. So we have to keep on observing this. Abnormal walking patterns or inability to walk. Now let's understand what a normal hip looks like, subluxated hip looks like, and dislocated hip looks like. If you see the normal picture, in this, the head of the femur is inside the acetabular socket completely. There is no, like, it's completely inside. And in subluxation, if you see, the head of the femur is little away, but it will not be out of the socket, but it will be little away from the socket. It could be displaced below the socket. Dislocation, meaning the head of the femur is completely outside the socket. It could go posteriorly, it could go anywhere, but then it is not inside the socket, and this is a very this might cause a lot of pain to the child. The second most important factor, like associated problem, is swallowing difficulty in CP. So this also is a very important topic for parents to understand and identify the fact problem that they go through. So generally, children with spastic quadriplegia or dystonia will have this experience of swallowing difficulty. How can we identify if the child has swallowing difficulties? Because of regurgitation. Regurgitation, if you try to feed something to the child will take it out. There will be heartburn, there will be unusual weight loss. If you see that the child is significantly losing a lot of weight, if there is hoarseness of the voice, meaning if the child has heavy voice, or if there is any cry that is very heavy, then you'll have to rule out why it is so, and you need to understand if there's some issue with the eating or swallowing, if the food is getting stuck in the esophagus or something. Getting food stuck in throat or lower area in the chest, gagging and coughing while attempting to swallow, and even excessive drooling. Also, one thing which can be included is the positioning of the child while we give the child food. Even if you make the child sleep and give the food, that also could be a factor, and also might cause aspiration pneumonia. Now, eating difficulties may cause food aspiration, cause aspiration of food and fluids into airways, which is a major cause of mortality and morbidity. And difficulties may develop or worsen in the later stages, while you can use a feeding tube for the child. It is necessary that the caregivers and professionals be very attentive and monitor the first symptom of food difficulty, which is very important. We can prevent a lot of hospitalization, a lot of hospital stay, and use of NG tube or PEG tube if we really identify in time that there is some difficulty for the child to eat food, or even chew or swallow or drink. But if there is dysphagia that persists, that means if there is swallowing difficulty that persists, NG tube can be given by the doctors. That is nasogastric tube. The tube is inserted from the nose through the esophagus, it goes to the stomach, and only liquid intake can be given. Meanwhile, we can train the child for oral intake. PEG tube. PEG tube is a percutaneous endogastric tube. So this tube will directly go into the stomach of the child, and we can keep on feeding it in intervals, regular intervals. Now, moving on to the assessment of CP. Why is it important to assess a child? It's important for us to understand what type of CP the child is, or if there is any, how can we understand what type and what is the pathology that they have. So we can look for alignment, we can look for base of support, weight shifts, center of mass, and postural control. What is alignment and why is it important? So alignment is the ability to maintain the head, trunk, and pelvis in one single line. So we need to look for the alignment in all the different positions, like on the back, on the tummy, while sitting, supported, unsupported, standing, supported, unsupported. It's very important for us to understand if the child's sit all position alignment is fine or it's not fine. We'll have to see that. In this image, if you can see, in this, the child is made to sit on the chair, but then because of poor posture and poor alignment, it's not able to do so. So the head, trunk, and pelvis is not in alignment. That means there is some issue of it for the child to hold on to himself. Then comes base of support. So base of support, it refers to the area that includes every point of contact that a person makes with supporting surface. It also refers to the distance between the two legs. It could also be the distance between the 2 feet or hand, or distance between the 2 crutch. So children should be walking with proper base of support. Or if there is abnormal base, then it looks like this. Abnormal meaning this is a narrow base. If the child has a tendency of the hip and knee turning inwards and making the base very narrow, whereas this child, the base is excessively wide. It's not normal to have this wide base of support. Weight shift. So why is weight shift important? It is basically the ability to shift weight of the body from one point to other. We have to understand how a child is able to shift its own weight in all different positions, that's sitting, standing, and while walking, if he's shifting better weight or no. How can we tell that the weights are shifted well is by these planes, that is the transverse plane, the frontal plane, and the sagittal plane. What does the transverse plane tell you? It divides the upper and the lower body. The frontal plane divides the front and the back body, while the sagittal plane divides the right and the left side of the body. Postural control. So postural control basically will tell you to build up the posture against gravity. Like it'll make you upright and ensure that the balance is maintained. So we have to see this in a child. If the child is able to maintain its posture even on tummy, or if it's able to maintain the posture in sitting, in supported sitting, in standing with support, or if it's able to maintain the posture in normal upright position. It's very important. So to fix the orientation and position of segments in space. Moving on to the management of cerebral palsy. In our hospital, we have a multidisciplinary approach. That means we approach a child in a holistic way. With a child with CP goes through a lot of things. So we have a lot of the whole department, like all the faculties over here who try to help the children with CP. So social care, nursing care, speech and language therapy, teaching support, occupation therapy, physiotherapy, dietitian, voluntary organizations, pediatric neurology, psychology, orthopedics, child authorities, ophthalmology, and pediatric medicine. So all of these departments, we work in hand, we discuss their goals, and then we try to come on to a point and then do the therapy after discussing with each other. Medical management. Since children with CP go through a lot, like there is uncontrolled body movement, there are seizures, epilepsy, there is spasticity, there is pain, there is constipation. These are the medications that are used for the following. Anticholinergics can be used, anticonvulsants can be used, antispastic medications can be used, anti-inflammatory drugs can be used, and stool softeners also can be used. There's also something known as Botox injection, which is used to weaken the overactive muscles. It is injected directly into the muscle, which acts by releasing the neurotransmitter, that is acetylcholine, and brings about the muscle inhibition. It is given in spastic CP. The effect begins approximately 24 hours, and then it can last up to 2 to 6 months. But then after Botox is taken, it's very important and advisable to do physiotherapy rehabilitation, on regular basis and vigorously after Botox is done. What are the surgical interventions that a child of CP undergoes? Since we all know that the child has a lot of spasticity, or there is a lot of deformities that they have. So neurosurgical procedures, selective dorsal rhizotomy is done for children with severe spasticity. There is they try to damage the nerve that supplies the muscle, which is very spastic. Like then they can actually reduce the spasticity of the muscle. Orthopedic surgical procedures, that means contracture release. Contracture release for children who have fixed flexion deformities of the knee, or if there is equinus deformity, varus deformity, they can the contracture release can be done for those children. Tendon transfers. Tendon transfers are done for children with severe tightness or spasticity, wherein there is no movement, like there's no movement happening at all, or there is stiffness of the joint. That's when the tendon transfer is done. A good tendon is transferred to the bad tendon from the same body. Osteotomy. Osteotomy is a part of bone that is excised or removed. Arthrodesis is fusion of the joints, fusion of the joints. Now, what do we do here? We do cell therapy and neuro rehabilitation. Now, what is cell therapy? So over here, we use adult autologous bone marrow derived mononuclear cells. So these cells are aspirated from the bone marrow of the hip bone, that is the ischium bone. We aspirate it, and we give it in the laboratory for separation, and then after separation, the mononuclear cells are separated. Further, they are injected into the spinal canal. Through CSF, it goes and travels to the affected areas of the brain. So cell therapy, basically cells are like trees, okay? So they require fertilization, they require nourishment, they require water. But then we have to be able to give out branches and trees. That's why that's how cell work. If we do cell therapy along with neuro rehabilitation, it will really be very effective and it will be very beneficial for the child. What are the integrative therapies? What is HBOT and ozone therapy? What we do over here? We also do integrative therapies. That is HBOT. It is a hyperbaric oxygen therapy. HBOT is a non-invasive procedure that floods the body with 100% of oxygen. So this occurs in a closed, transparent chamber which can administer oxygen at the pressure higher than the sea level. It is around 30 to 45 minutes. This is the chamber that we have. And in this, the child is, the child has to go into this for 30 to 45 minutes, where there is 100% of oxygen that is given to the child. It will improve the child's immunity and will help the child fight against infections. We also do ozone therapy. Ozone therapy uses pure 100% medical grade oxygen ozone combination to supply higher amount of oxygen to the tissues at the cellular level. So basically, ozone is a very powerful and versatile gas which will help our body to fight against infection at the cellular level. It will also increase the oxygen carrying capacity by triggering the body's antioxidant response. This is the ozone therapy what we do. It can be given through ears or it can be given rectally. What is a neuro rehabilitation now? So as I told you, we work together, the physiotherapist, OT, speech, aquatic, psychology, special educator, and the nutritionist. We all work together for the betterment of the child. What does occupation therapy do? Occupation therapy will work on the oromotor sensory integration, which will help in the eating, chewing, feeding, drooling. All these are very important factors, and occupation therapy works on that. They'll also work on the positioning of the child for tabletop activities like adaptive and assistive devices for ADLs that they require, like feeding, various hand function like reaching, grasping, and releasing. What does the psychology department do? It's a behavioral therapy, what they give in CP. What are the major challenges that they face? That's limited compliance, aggressive behaviors, and not banding for the needs. How do they tackle with this? They give a lot of positive reinforcements, negative reinforcements. They use token of economic concept, and they keep on working on use of non-verbal gestures for utilizing or manding their needs. Speech therapy. Speech and language therapy will try to improve the child's communication by strengthening the muscles used for speech, muscles used for swallowing, chewing, and oromotor skills, which will help further to reduce the swallowing issues that they go through. Special education. Special educator will help the students with CP to participate in the classroom activities by providing them with the appropriate accommodation that they require or the adaptive tools that they require for the same. What do diet and nutrition does? Diet and nutrition will take care of the child. If the child has some issue with swallowing and chewing, there will be a lot of issues with, they might go through a lot of, deficiencies or malnutrition or undernourishment. Diet and nutrition is very important for the children with CP so that they are well nourished and there is better development of the child and a better development of the brain of the child. Now, what are the bases that we work on? Like, what is rehabilitation and what is its implication, and why are we doing rehabilitation? Is because of neuroplasticity and motor learning. What do you mean by neuroplasticity? Neuroplasticity is the ability of the brain to adapt to different changes from individual environment by forming new neural connections, which means when you try to teach a child a new task, the brain rewires or makes new connections for that. So if you example, if you are trying to ride a bicycle, and your focus will always be on riding that bicycle or balancing yourself on the bicycle or taking care of the road while you're on the bicycle. But once you start doing it, or once you adapt that change that you have to do it, that's how neuroplasticity works. Gradually you will learn that you'll have that confidence to ride on the road, and you will not have to focus on what you're doing and you'll simply do it. So that's what neuroplasticity is. Through neuroplasticity, the brain is consistently rewiring itself and modifying its connections. So also a better example for neuroplasticity could be a new language learning. When someone is trying to learn a new language, the neurons which are responsible for language acquisition will develop a lot of connections in the brain. What is motor learning? So repetition. Motor learning involves learning a skilled task and then practicing with a goal in mind until the skill is executed. So initially these links what are made in the brain could be very weak, but then this links or the neural connections, to make it stronger, we need to have repetition and practice, and that's how motor learning works, and that's how all the rehabilitation works. We have to do a lot of practice and repetition in every activity that we give a child. For example, learning to play a song on the piano initially takes a thought and practice before the task is automatic and executed skillfully. What are the aims of physiotherapy? Firstly, it is to promote independence in all aspects. Like the gross motor independence is our primary aim. Increased participation, facilitation of the motor development and function, improve strength and endurance, enhance learning opportunities, ease challenges associated with daily care. Moving on to the treatment of spastic cerebral palsy. Now, firstly, let's understand the importance of stretching the tight muscle. So it's very important for us to elongate the muscle before we strengthen it. So that's one of the reasons stretching is a very integral part of therapy before we start the therapy, so that once we try to work on the affected muscle, it is little loose and it performs better. So stretching the tight muscle, firstly of the upper limb, wrist flexors. So why do we stretch the wrist muscles? Is because if I have mentioned in my previous slides that the children will have a lot of stiffness or tightness of the wrist and hand muscles. So wrist flexors are stretched for the same. Lateral chest wall stretching is given because a child will have a lot of even the rib move, like the chest muscles and the back muscles have spasticity. So it's very important to stretch the chest for better mobility of the rib cage and the spine. Anterior chest wall is also done for the same reason, because there's tightness in the rib cage. Now let's move on to the stretching for lower limbs. Hamstring muscle stretching. If you see, this is a very tight muscle that this child has, and his hamstring muscle is being stretched because he has excessive knee bending, and because of which the muscles have got tightened. And for improving his ADLs of function or standing or better posture, stretching is very important. Tendo Achilles. Tendo Achilles is TA muscle that this is the reason why children go on tippy toes. This is the muscle which is causing tightness, and that's the reason they go on tippy toes. That's why we need to stretch the muscles so that they weight bear better and perform better activities. Adductor of the hip. Adductor of the hip muscle stretching is, as I told you, for excessive scissor pattern or W sitting. There'll be a lot of tightness in this part of the muscle, that is the adductor of hip muscle. That's why we have to do the stretching. Sorry. Now, what all activities are useful for developing neck control? So let's observe this. Tummy time, promoting neck control. In this, the child is on the tummy, taking weight on the elbow. We've given her a towel roll. So this child is unable to use her neck muscles. She is unable to come up to the, like, cannot extend the neck. That's why the towel will really be useful for her to help her come up. And tummy time is also very important for them, as she's weight bearing and trying to look up. Bouncing on a ball. There are reasons why we can, we make a child bounce on a ball is for improving firstly the arousal level and also the neck control. If you see, the child is very happy and she is trying to look up with the neck roll. Then comes sitting in 90-90 position. That means sitting in a better alignment. This also will promote the neck control. If the child is sitting with a good support on the leg and good support in the hand, we expect the child to take weight on a hand, and we give her auditory cues, or we can just talk to the child and then see if you can see the child is trying to hold her neck and her posture has improved. Kneel standing, which also will promote neck control. In kneel standing, the child is taking weight on the knees, and I'm passively holding the hand of the child because she's unable to do so. And I'm expecting her to look at the phone with the song that she likes. And through that, I want her to, look at it and hold her neck. And she's doing it for a few seconds and then getting it down. Now, supported standing also can promote neck control. So supported standing is also giving the child a lot of weight bearing on the lower limbs, lot of weight bearing on the upper limbs. But with that, there is neck control also that is happening. You can see the video. I've passively held the child and the hand is also held. But then she is trying to look up with a better posture. Activities to develop trunk control. So activities like quadruped with reach outs. This child has that opposite side which is affected. That's the right side which is affected, and she is expected to take the object, and there is weight shift happening, and she's also utilizing her trunk muscles. Sitting balance. Sitting balance. The child is sitting, is just learned to sit, and we are expecting the child to reach out towards the ring set while he does not let himself fall. This is developing sitting balance and working on weight shifts while the child doesn't fall. Now reach outs on the ball. If you see this child, she is expected to reach, like, go translate herself towards the thing that she wants to take. It's very attractive for her, and she will go. She's expected to go there, hold on to herself, not fall, weight shift, take the object and come back. We are working on a lot of weight shifts and trunk control and a lot of hand function. Also eye-hand coordination. Kneel standing while promoting neck control. So In this, the child is passively held up and expected to look up. I'm not letting him go behind. I'm just wanting him to maintain his neck in the available range of motion while he takes weight. There's a mirror in the front and we are expecting him to look at the mirror also. Prone extension activities, meaning the child is expected to come on the tummy and on a moving object, she has to, take both with both the use of hands, she has to lift the ball and put it in the basket while she utilizes her back muscles. Prone extension can also be on a stable surface wherein she is held onto her leg hips and she has to clap with both her hands together while she sustains her extension. Now, trunk rotations can be taken on a moving of a swing. Like while we move the swing, she has to rotate her body and go towards the ball, not fall and just take the ball and come back. Where she's using a lot of trunk rotators, she's doing a lot of weight shifts while she's holding on to herself. Knee standing activity on a stable and an unstable surface. In kneel standing, if you see that child is standing on knees and we are giving her a reach out which is little higher and we are expecting her to go towards that object without her falling down, and she has to maintain that position. We are working on a lot of co-activation of the muscles and lot of hand function and lot of eye hand coordination, while she has to swing holding on to herself and she's expected not to go behind or not to come ahead. She has to maintain that position. This is also very useful for co-activation. Co-activation meaning working of two muscles together. Now coming up to sitting. Coming up to sitting can be done on a ball or on a stable surface, that's a mat. So this child is expected to take weight on the affected side and we are giving her some reinforcement that she has to come and eat it. That's the only reason she's come up for. So she has to take weight and come up to sitting and eat the reward that she's got. Supine to sitting on ball, this child has to hold a ring and utilize his core muscles and go to the ring set and put the ring without falling, and he has to maintain his own body. Pelvic bridging, meaning the child has to sleep on the back with the knees bent. We have to command the child to lift the buttock up. This will really help the back and core muscle to get activated, the gluteus muscle to get activated. That is the buttock muscle. Donkey kicks. Donkey kicks will be the child has to go on all fours position and the child is expected to kick the leg from behind like a donkey does. So that's why we call it donkey kicks, where she is using a lot of buttock muscle, a lot of core and back muscle strengthening is happening over here, a lot of weight shifting to opposite side, and there's hand weight bearing also what is happening. Now sitting in 90-90 alignment, where this child is expected to sit with forming good base of support and with the shoes, and so he has to sit in erect position while he controls his upper body, takes weight on the legs and takes weight on the hands as well. Learning to sit on mat with supported hands. This child has just learned to sit, so the affected side we've put a pedi wrap and she's expected not to fall and hold on to herself and go behind. So she does it very well. She just goes behind while she's maintaining her trunk muscles and core muscles. Now in this child is asked to hold the trapeze or a suspension, that she has to hold on to it and lift both the legs together and kick the ball together. So she is using her hand muscle, her grip muscles, her postural muscles are getting stretched, which is very good. Her lower abdominal muscles are working. Her eye and leg coordination is improving. If you see this is a very good activity. She has to lift it together. Yeah. Now, extension activity. In this, the child is expected to stand and reach out to the clay that is kept above it, and he has to go and take it, while the attitude of posture that he has is that he usually is in flexion or bend. That's the reason I'm trying to give him a lot of extension, or hand has to be straight while he reaches out towards it. Pull to stand activity. These are the activities which will be helpful for sit to stand. Pull to stand. In this, the child is asked to form a base at feet, and like we are trying to make her form a base at feet, while she has to lift her hand, and her hand is well supported over the ladder. She has to hold on to it and pull her body while she forms a base and pulls her onto herself. She does this very well. Then pull to stand can be done in various ways. The child has to take support of that one stick that he has, get up and reach out towards the ball that we are showing him. Pull to stand can be done like this also, wherein I'm asking him to hold the stick or rod that I have in my hand. He's pulling onto it and standing up himself. Now, how can we develop standing balance? Standing balance training with double support. Here, the child has to take weight, like we've worn calipers for him because he has a tendency of bending his knees. That's why we are wearing the splints or the calipers. That's how he learns to weight bear, and there is stretching that is happening. So with that, he has to hold on to two canes that he has, and he just has to reach on to the ring that I'm going to show it to him while he shifts his weight and learns to take weight on the opposite limb and then tries to stand. Balance training can be done with single point support also, that is one cane. Here he's asked to hold a stick and stand while we give him reach out in extension, because he is a case of crouch spastic CP. That's why I'm expecting him to push his knee and stand up straight while he performs all his activity in the above plane, that is an extension. Now attempting to stand with calipers alone. Here, the child is also like she's wearing calipers, and we are expecting her to stand straight and alone, and we are giving her a lot of weight shifts while we have not supported her. She's just trying to shift her body weight and learn to stand in a better, like without swaying or falling down. She's working on her, a lot of core muscles are working, back muscles are working, a lot of weight shift is happening in this. Standing can also be done on a standing frame, wherein the child is support. Like the lower the support, the better the child learns to recruit the above muscles. In this case, the child has a better trunk control. That's the only reason I've put the strap on the knee. And we can also put the strap on the hip or on the chest, depending on the level of issue that the child goes through. Now, how can we prepare a child for walking? There is preparation that is required for a child to walk. So half kneel standing. Half kneel standing is a very important activity, wherein it's also known as work stance position, where the child is, taking weight on the front hip and like knee, and there is extension activity that I'm trying to give. There is dissociation of the hip that is happening. Trunk and pelvis dissociation activities. This activity is like I'm holding the child onto the pelvis. I've taken the other leg of the child outwards, and he is expected to rotate himself and take the object. So this is the dissociation is happening in trunk, pelvis, and also in the upper back. Dissociation of pelvis and trunk can also be done on the ball, where the child is in one leg is in flexion and one is suspended down, wherein he has to reach towards the ball while making his spine straight and holding onto it. Kicking a ball in sitting and standing. Ball kicking is very important activity for the child to understand to lift the leg. Basically, we are trying to strengthen the hip muscles for them to understand the importance of lifting, but it should be in a correct pattern, and the body alignment while we do it should be very good. We cannot compromise on alignments anytime. Kicking, so he's trying to lift his hip and attempting to kick the ball while he is looking down to it. Then it can also be done in sitting. where I'm not letting him go behind and not compensate or use compensatory muscles, but I'm trying to just strengthen his quadriceps muscles. That is this muscle. Now initiating steps, stepping up and down with support. In this, the child is holding the walker and I'm asking him to lift his leg up and step onto it while you can take it down as well. If you see, the child will do it. Yes, the higher the step, the better for a child, but then we can start gradually with this level step for like just for the strengthening of hip muscles. Stepping up with reach out. In this, the child is asked to step up, hold on to the cane that he has and reach out towards the toy that we are showing to him, whereas he takes weight on the stepped leg and reaches out, tries to reach out. Walking with walker support. This is a frame walker that we are making her walk with. The only reason why I'm giving it, she has to hold it up is because she has a tendency to bend her back and we don't want her to do that. That's why her upper limb muscles are also acting, her core muscles are acting, and we are not letting her go into scissor pattern. That's the only reason we have put the divider, if you can see the green divider. Now, walking with support over a posterior walker where the child has to walk. There's a divider again because the child, if you see, has a tendency of internal rotation and scissor pattern. This we are trying to stop that with the divider what he has, and he's we are encouraging him to walk as much as he can alone. This activity is also good for the child to understand or hold on to the rope, and with the he's actually pulling down the rope, but then we expect him to, yes, he can do this, he can he just has to hold on to the rope and lift his leg while he walks for a better trunk posture. Walking with a cane, this child is asked to lift his leg while we are teaching him how to use a cane, take weight shift and lifting the cane, putting it ahead. And there's a divider where we do not want him to go into scissor pattern again. Now, activities for vision. So vision also is one of the factors which is affected in children with CP. So that's the reason vision therapy is very important, because that part of brain which supplies the vision will be involved. That could be involved. So vision therapy also is important for the child to learn to track the object, to fixate the object, or even we can promote vision therapy can be done for developing neck control as well. So there are lights that we can show, lights like red light, dark color lights like red, green, yellow. These are the lights which are very dark and are fascinated to the eyes. So we expect the child to, unless the child tracks it, we'll have to continuously do it. Every day, even if for 15 to 20 minutes, if the parents do vision therapy, it will be really effective for the child's vision to develop. Now, this was the treatment protocol for spasticity. Now, moving on to the treatment for dystonic CP. So, for dystonia, it's basically preventing them to go in the pattern in any movement that we give. So, we are trying to inhibit that pattern and give or promote a lot of flexion pattern or strengthen the core muscles for that. So, positions for developing neck control with while preventing dystonia is tummy time. Like in tummy time, I'm not expecting this child to go in hyperextension, or there shouldn't be excessive extension. Even if you're giving some cue or like a visual or auditory cue, if you're showing him a toy or a phone, then the child, it should be on the one level below the eyes. It shouldn't be above the eye level. Whatever you give, you shouldn't give it above the eye level, because the child will have the tendency to go behind, and then he will not learn to sit or utilize his muscles. In this, the child is expected to do prone extension, and while his neck is held, he is not going into dystonia. He's just taking weight and trying to extend his neck. In this, the same activity. I'm expecting him to look at himself in the mirror while he is taking weight and sustain this. I'm preventing hyperextension by giving him a lot of weight on the hand. Also, it's very important for us to develop the core muscles in a child with dystonia because those are very weak in them. I'm expecting the child to come up and touch his head to him so that he understands the concept of the activity, and he has to just touch his head to his head. In this, the child is expected to come up to sitting. Yeah. You can see this. He is expected to come up to sitting. Now, we have to teach children with dystonia to have a proper alignment and sit in a position where they do not need to go behind. So if this image, if you can see, this child is a case of dystonic CP wherein he has the tendency to excessively go behind, but then now he has learned to sit with better alignment, and he's sitting in this 90-90 position. And I've used a hip abductor because he has a tendency of crossing his legs while he sit, hips while he sit, and he has learned to sit alone. I'm just holding him, like trying to hold on to him because I don't want him to go behind. This also is a child of dystonia, child with dystonia, wherein he's learning to take weight and keep his head in neutral. I'm trying to hold on to him so he doesn't lose his balance. Now, sitting for a child with dystonia on a stable surface. If you see this, the child is seated with hands well supported over the mat, and he is trying to hold his head in neutral position while his posture is good and he's not going behind. While this child, we've used pedirap meaning because he has tightness in the upper body. We want him to take weight, so that's why we use pediraps so that the weight bearing he does it better. So we've given him some video on the phone so that he doesn't look up and go behind. In this, the child is sitting on a bench where his spine is in a better position, and he's taking his elbow weight on the table, and he is trying to extend his trunk in a better position. Now, sitting on an unstable or a moving surface. So we promote this like swing activities. I just want him not to go behind and hold on to his own body. He's trying to open his fingers and trying to hold on to the swing. He's not going in dystonia with that. This is the same activity. Here he is taking weight on his hand and the spine is straight and the head is in neutral. He's trying to maintain that position. He's also trying to hold. On an unstable surface, meaning we can make them, improve the weight shifts on a balance board without going into the pattern. You can see this. Yeah. Weight bearing activities in closed chain. It's very important for us to give them a lot of closed chain activities because once they have to learn to use their one of the body part which is not weight bearing. So closed chain activities will really be useful until they learn to take weight on themselves. So I'm expecting him to maintain in this position while he looks, the head is extended and there's no other body component which is going in pattern. Kneel standing. Now, dissociation activities for children with dystonia. If you see this guy, he is one leg is on the bolster and the other one is suspended down. His posture is good, his head control, he's trying to look to that side because he had a tendency of looking at only one side while we are giving him cues to at the opposite side so that he learns to rotate his neck towards the affected side also while his hands are like have good weight bearing. This also has dissociation where I've given pediraps for the child for him to weight bear better. Now sit to stand activity without like preventing the pattern can be done. In this, he has actually gone behind and I'm trying to get him down. We are trying to ask him to sit, but he is trying to go behind. So we cannot push him so much. We'll just wait till the movement subsides and then he'll come down again. Now standing in proper alignment without going into the pattern is this with good alignment. And this, so we are like he's weight bearing on the ball over a pillow and he's trying to come up straight, whereas without going into the pattern. Also in standing frame, we can give him a lot of activity for upper extremity. Like we are expecting him to lift his hand up and pop the bubble that is there in front of him. A lot of things will be worked like the eye-hand coordination, the hand function will be used. Now, in this, if you see this video, this child has a very bad hip, like his both the hips are internally rotated and severe deformity. We can prevent the deformity by giving a lot of adaptive like equipments like this. This is an abduction pillow. If you see, there's a lot of difference in this. This is a good alignment that he's sitting in, and we have to promote such good alignments because in this there will be a lot of issues that he will have in like he cannot walk, and that's the reason we have to give him a lot of like we cannot expect the child to deteriorate. We have to give them a lot of positive enforcements. How can we handle a child with dystonia? We can do this. In flexion, we have to promote a lot of flexion. This is a hammock wherein we are expected, he's expected to not go behind. We are just holding on to him. As I told you, we are promoting a lot of flexion activities, like bent activities. And this. Now, what is aquatic therapy in CP and how is it important? What are the aims of aquatic therapy? Aquatic therapy will help in facilitation of the muscles. It improves balance and coordination. It improves hand function. It improves the oromotor strength. It's used for assisting with gait and locomotion. It reduces the stress and promotes relaxation. We do aquatic therapy over here for reducing the dystonia, for improving the neck control, for mouth closure and to reduce drooling, for improving the hand function while we are working on the trunk and the neck control, and also eye hand coordination and promoting a lot of flexion, for gait training, and for walking over a treadmill in the pool itself. These are the adjuncts or the AFOs that we use for children with CP. These are the adaptive equipments we use for facilitation. These are the walkers, bolsters, balls, and steppers and stools. This is a spio which we use for better trunk and alignment and posture. Sitting alignment with and without a spio. If you see this child is sitting in a very slouch posture, whereas after spio, the child is sitting better. This is just to give them a feedback that they have to come up. These are the references. And thank you. Still exercises to it. So there are a few questions that we have. पालसी बच्चे के माता पिता है, हमें इस सेरेब्रल पालसी बीमारी के बारे में सब कुछ पता है, आप इनकी फिजियोथेरेपी के बारे में बताइए जिनसे इनकी टाइटनेस कम हो जाएगी. सो मेरे पास एक सवाल है प्रवीण मिर्धा जी. सो आप पूछ रहे हो मैडम हमारे बच्चे को सेरेब्रल पालसी है, मुझे इनके फिजियोथेरेपी एक्सरसाइजेस के बारे में पता कराना है. सो जी प्रवीण जी, मैं डॉक्टर संपदा हूँ. मुझे आपके बच्चे को पहले हमें असेसमेंट करनी पड़ेगी. आपको एक फिजियोथेरेपिस्ट असेस करेंगे, उसके बाद आपको जवाब मतलब कैसे क्या करना है बताया जाएगा. बिना बताए या बिना देखे हम कौन से टाइप का सीपी है हमको देखे बिना हम नहीं बता पाएंगे आपको. तो आप प्लीज आप अपने बच्चे को आप फिजियोथेरेपिस्ट को कंसल्ट कीजिए एंड पता कीजिए कौन से टाइप का सीपी है, क्या क्या चीजें नहीं आ रही है, क्या आ रही है, उसके बाद कर सकेंगे. Shriram, baby's age is now 4 years. Still there's no head control. Any exercises to improve head control? So hello, Shriram. So yes, there are a lot of exercises that I have shown you on the videos, but then it would actually be better that you actually go get your child checked and assessed from a physiotherapist. I cannot give virtually the videos unless I assess the child for the same. Thank you.